Good morning, everyone. Welcome to the Cleveland Clinic. Good morning, everyone. Welcome to the Cleveland Clinic Abu Dhabi MS Day webinar. My name is Anu Jacob. I'm a neurologist and the director for the MS service here. 30th of May, the coming Monday, is a World MS Day. It's a day when we focus minds globally, increase awareness of MS amongst the MS community, patients, their families, healthcare providers, employers, and society as a whole. It's an opportunity to share knowledge and increase awareness. As part of that, we're organizing this year's seminar. Today, the topic is on a secondary progressive MS. What is SPMS? How do we prevent it? How do we treat it with disease-modifying drugs? How do we manage the symptoms? And what is the future of SPMS treatments? My co-host today is Aslam Abu Samra. Aslam is one of our two MS nurses. You might have met them both, Gina and Aslam. Gina is not here today. It's a birthday. She's relaxing. So happy birthday, Gina. Can you put the next slide, please, Ritik? Oh, sorry, Seb. So to listen to the webinar, you have to make sure to check the translation option at the bottom right of the screen and choose Arabic and select the mute original option. So at the bottom of the screen, there is a option to choose Arabic and select the mute original option. So you can hear it in Arabic. We have interpreters available who will interpret for you. So as I was saying, so Aslam is one of our specialist MS nurses. And she's been there at Cleveland for nearly 5 years now and is an invaluable member of our team. I will hand over now to Aslam to chair the session and introduce the subsequent speakers. Thank you. I think you're live, Aslam, now.
Hi, everybody. So as Dr. Anu said, we are today here to celebrate our MS Day, which is coming on May 30. And first of all, I want to thank Dr. Anu for his introduction. So today, we will be discussing all about the secondary MS progressive, and we will have three presentations with Dr. Anu, Dr. Beatrice, and Dr. Victoria. And as you may know, that we have the collaboration with Sheikh Salama Foundation with Cleveland for our MS program. So we are delighted today to have Mira Al-Mutawwa, who's the manager of the health program at Salama Al Nahyan Foundation, to speak with us. So we will be having now a short talk with Mira.
Ladies and gentlemen, on behalf of the Salama bint Hamdan Al Nahyan Foundation, I'm pleased to welcome you to this educational webinar on the delaying and treating of secondary progressive multiple sclerosis. We gather today in the lead up to World MS Day, a global initiative that brings individuals and organizations together to share stories, raise awareness, and shine a light on the issues of greatest importance to the international MS community. From 2020 to 2023, the theme for World MS Day is connections, and I could not think up of a better word to describe the transformative impact that the Neurological Institute at Cleveland Clinic Abu Dhabi is having on the MS landscape in the UAE. By connecting people with the most advanced tools and resources for the diagnosis, treatment, and understanding of MS, the Institute is changing the way that we think about and approach MS from a medical standpoint. However, just as importantly, it is also ensuring that people living with MS and their families know that they are not alone, and that an entire community stands ready to support them in a wide variety of ways. As a foundation, we're immensely proud to support the work of the Neurological Institute at the Cleveland Clinic Abu Dhabi. Above all, we are grateful to you, the members of the MS community, for sharing your stories, for supporting one another, and for continuing to participate in conversations like the one that we are having today. None of this would be possible without your involvement. So thank you again for being part of this important discussion on the occasion of World MS Day. Thank you. السيدات والسادة، بالنيابة عن مؤسسة سلامة بنت حمدان آل نهيان، نرحب بكم في هذه الندوة التي تناقش موضوع تأخير وعلاج التصلب المتعدد التقدمي الثانوي. نجتمع اليوم بمناسبة اليوم العالمي للتصلب المتعدد، تلك المبادرة التي تجمع الأفراد والمنظمات والهيئات المعنية للحوار وتبادل التجارب والخبرات ورفع مستوى الوعي بالقضايا الأكثر أهمية لمجتمع التصلب المتعدد. وعلى مدار الفترة من 2020 إلى 2023 يتبنى اليوم العالمي للتصلب المتعدد موضوع نتواصل لنواصل، ولا يسعني التفكير في كلمات أكثر دقة ومصداقية لوصف الإسهامات الجليلة لمعهد الأعصاب في كليفلاند كلينيك أبو ظبي في بناء جسور للتواصل مع المجتمع وتوفير أفضل خدمات الرعاية للتصلب المتعدد في الدولة، ومن خلال إتاحة المجال للحصول على أحدث أدوات وتقنيات تشخيص وفهم وعلاج التصلب المتعدد وأكثرها تطوراً، يساهم المعهد في إحداث تحول جذري في رؤيتنا وتفكيرنا وتعاملنا معه من وجهة نظر طبية. وعلى نفس القدر من الأهمية تأتي جهود المعهد في دعم ذوي التصلب المتعدد وعائلاتهم، والتأكيد على أن المجتمع بأكمله يدعمهم بكافة السبل الممكنة. وبينما تفتخر مؤسسة سلامة بنت حمدان آل نهيان بدعم مبادرات معهد الأعصاب في كليفلاند كلينيك أبو ظبي، نعرب عن عميق تقديرنا لكم أنتم أبطالنا الأعزاء لشجاعتكم في مشاركتنا قصصكم وتجاربكم، والتزامكم بتبادل الدعم والمساندة، ومواصلة حضوركم المتميز الذي يثري حواراتنا ولقاءاتنا. ونؤمن أن الخطوات التي قطعتها دولة الإمارات في مواجهة تحديات التصلب المتعدد لم تكن لتحقق بدون مشاركتكم، لذا نجدد لكم الشكر على حضوركم هذه الندوة في اليوم العالمي للتصلب المتعدد. شكرا لكم.
So we would like to thank Mira and Sheikh Salama Foundation. And now we will move for our first talk with Dr. Anu Jacob. You just met with Dr. Anu Jacob. So Dr. Anu Jacob, he's the director of the MS program at Cleveland Clinic. And he has received his doctorate in neurology from India. And as well, he's a member of the Royal College of the Physician and the Board of Neurology in the United Kingdom. We'll leave you now with the presentation of Dr. Anu.
Can you all see my screen? Islam, can you see my screen?
Yes, we can see it.
Excellent. So good morning again, everyone.
Doctor, sorry, can you switch it because we can see the presenter view?
Switch what?
We can see the presenter view currently.
Okay, let me see. Can you see me now?
No,
Oh, I see what you mean. Okay. Okay. Use slideshow now.
Yes, perfect. Thank you.
Okay. Right. So let's go to SPMS and how we can prevent it. Now, you will all know during our interactions with us that your MS is because your immune system is mistaking your nervous system as foreign and causing damage. To understand SPMS, I think it's important to understand at least a little bit about our nervous system. Our nervous system, particularly the brain, is perhaps the most fascinating of structures in our world. Simply put, this is how it works at the very simple level. The finger touches the flame, signals go up the nerves into the spinal cord and then into the brain. And then the brain's motor area or the strength area will send signals down the spinal cord into the arm and make the muscles contract. In MS, the problem lies in the brain or in the spinal cord. As you saw, it's all electricity. As in any electric wire, you have a cable inside and insulation outside. Otherwise, there'll be short circuiting and malfunction. In the nervous system, we have the copper wire or the axon inside, and then there is the myelin sheath outside. And this myelin sheath is produced by these cells called the oligodendrocytes. Now let's move to the immune system. The immune system is produced in the bone marrow and in the big bones of our body. This is the hip bone, that's the thigh bone. And inside the thigh bone, we have the bone marrow. And the bone marrow has cells called stem cells. And these stem cells produce many subtypes of cells. We have platelets, which make the blood clot. We have red blood cells, which are important to carry oxygen. And then we have white blood cells. The white blood cells, there are two kinds, T and B cells. And these two cells are responsible for the problems in MS. They are meant to protect us from outside infections and cancers, but sometimes they mistake our nervous system. In this picture, you can see that this is the nerve cell, and that is the myelin sheath over it. And there is a T cell which is attacking the myelin sheath. And this nerve is damaged. And here, but the second nerve can recover, while the last one has been permanently damaged. And this is what can happen in people with MS. So as I said, that's the normal nerve, and that is the damaged nerve. And the body can repair it and remyelinate. How much one recovers from an attack of MS depends on how active your immune system is and your ability of your nervous system to repair itself. So it's a balance between these two. If you are unfortunate enough to have MS, then you want a mildly annoyed immune system, which is not causing too much damage, and a nervous system that can really repair well. That is what you would want. Now, the million-dollar question is MS and what causes it? We know that it is not one reason. MS is because of an altered immune response against the nervous system, but that is because of something in your genes and something in the environment. And what is in the environment? It could be a virus, something called an Epstein-Barr virus, which is a very common virus, and things like lack of vitamin D, etc. I'm sorry to say that despite centuries of research, we don't really fully understand what triggers MS. But I'm sure we will get answers in the future. So these white blood cells, they cause inflammation. And your scans, you would have noticed, will have white spots. Here are these white spots in the brain. And there is some in the spinal cord here. And there is some more in the brain here. Now, what do these white spots cause? If it's in the spinal cord, you could have interruption of the signals that go up from your body into the brain and in the opposite direction. That can cause weakness. If it's in the brain, you can have one-sided weakness. If it's in the lower part of the spinal cord, you could have problems affecting only your legs. It could be numbness or pain if the nerve fibers that are affected that carry sensation. Here is the optic nerve. It carries sensation from the eyeball into the back of the brain. And in optic neuritis, this nerve is inflamed or damaged. And that leads to poor vision. This is the good eye, and that is the affected eye. The vision can be quite unclear. It may repair and you will get back vision. This is double vision or diplopia. What happens here? This lady is trying to look to the right side. The right eye is not moving. The left eye is moving, and that is normal. Why is it not moving well? Because the nerve that moves the right eye is affected. Okay, there's a mistake here. This is meant to be a right eye, but this is the right side that is abnormal here, and the right side nerve that moves the eye is affected here. This white spot that you see there, and that means the two eyes will see two different images, and that is called double vision or diplopia. So coming to what SPMS is. Now, let me, to explain this well, let us assume that, take an example of a person who had MS 50 years ago, before any good medicine was available. Okay, 50 years ago, someone is diagnosed with MS and there are no good medicines available. So that person will have a natural course of MS. And what is the natural course of MS? Let me show you a timeline. Time 0, time in years. Okay, this is the time in years, the lower arrow. This is the time when the patient was diagnosed with MS, time 0. And then 5 years from beginning of MS, 10 years, 15 years, 20 years, and so on. So this is the time course of someone who was diagnosed with MS 50 years ago when there were no medicines. On the upper arrow and the upward facing arrow, they can put the problems that the patient may get because of MS. Okay. You want the problems to be really low, but without treatment, it is possible that some people with MS will accumulate problems. So here is the first episode of MS that this patient had. He or she had a weakness of the legs. It's an inflammation in the spinal cord, transverse myelitis. Fortunately, it's only lasted about 2 months, and then the patient completely recovered back to normal. A year later, she had another episode, and this time too, she recovered very well. But about 2 years later, she had optic neuritis, and though she had some problems, it did not recover completely. Her new baseline was she had some permanent problem. Years went on, she had more attacks. Each time, some of these attacks would leave behind some problem. Another attack, because there are no medications. And then somewhere along around 10, 15 years, she started noticing that her walking was getting worse. The attacks became very rare. Here we have so many attacks, but here the attack is really rare, occasional. But her walking continued to worsen. And that transition around 15 years or so happens in most people who have relapsing MS without treatment. This initial phase is called the relapsing MS, where your attacks of MS. And this is secondary progressive MS or SPMS. We know that the attacks are caused by white blood cells causing damage. But we are not sure what the reason for SPMS is. Yes, the white blood cells do cause a problem, but it is not the only reason why relapsing MS becomes secondary MS. So these causes include getting old, genes, and many other things that are poorly understood, though much research is going on. How do we treat MS? What is the ideal drug? If I had a wish, what kind of medicine would I wish for? I would want a medicine which I will give to the person after the very first attack of MS. And after that, there should not be any more attacks. And the patient should remain well for the rest of their lives. That's what I wish for. That's what I hope and pray for. But unfortunately, we do not have a medicine of that kind yet. I'm sure it will come in the future. So how are we currently treating MS? We have very good medicines that act in the relapsing stage of the MS. The medicines that you might be on, including ocrelizumab or ofatumumab or tecfidera or tisabri, all those medications, Gilenya, they all work well in this relapsing stage and they attack the white blood cells. And they will reduce the attacks and patients have a much normal life. And hopefully the time when you become secondary progressive is delayed, is pushed out further. Will it be completely prevented? Well, we don't know the answer for that. So is it enough to choose medicines that delay progression the most? Or, well, the older medicines like interferon, Copaxone, they don't really delay the progression significantly. We know that because those medicines have been there for the 20 years. We know that in 20 years, they don't really do much. However, the new medicines, though they are very good, we haven't seen them for 20 years. So we don't know their effect in 20 years' time. We guess that, we believe that they will definitely improve the course of MS and will delay progression. So how does that help us? What can we do now to prevent secondary progressive MS? Well, the first thing to say is that you must use an effective MS drug that prevents relapses. Milder MS drugs probably will not be that helpful. And we know that from people who have used interferons and Copaxones in the past. Of course, the drug has to suit your lifestyle. And we will discuss this in clinics when we meet with you and choose a drug for you. We know for sure that stopping relapses will certainly delay progression. What are the drugs available? Well, we have the moderately effective category of Gilenya, Mavenclad, Tecfidera, Ponvoy. The highly effective ones called Lemtrada, Ocrevus, Tisabri, Kesimpta. The second thing to say is to protect your brain. You have only one brain. Whether it is MS or another problem, it's all going to affect it. So we have to really try to protect our brain. Do you know what the best way to protect your brain is? Okay. When we are young, when you are 17, in your teens and your early 20s, your brain is the fullest, it's the biggest volume. As we get older, the brain shrinks. By the time you are 70, your brain is about 1/3 of how you were when you were young. So the best way to protect your brain is not to get old. I'm joking. Well, if somebody finds a way of protecting your brain, let me also know. I would like to do that too. Anyway, the next best thing is to stop harming your brain. And this is a big problem in the UAE. In the Western world, people have understood this, but in UAE and in the Arab regions, people are still smoking, and smoke really damages your brain. So please stop smoking. You have only one brain. Alcohol in excess certainly damages your brain. So please avoid using excess alcohol. Losing weight will certainly help, especially in young people with MS. We know that weight reduction, excessive weight or obesity can lead to poorer outcomes in MS. Control your blood pressure, diabetes, and cholesterol. Each of these will cause small damages, small blood vessel damage in the brain. And whether it is MS or it's small blood vessel, it is the brain, your only brain that is being affected. So it's very critical that you control your blood pressure, diabetes, and cholesterol. Next is to try to stimulate your brain, help it learn and grow. And the things that will help for sure, based on research, is to exercise regularly. We know that exercise improves blood flow to the brain and stimulates brain function. It is not enough to exercise, you must have good posture. And because the wrong muscles, the large muscles of your back, your trunk, wrong postures can lead to a lot of unnecessary energy wastage, and having a good posture also helps. When you meet us, ask for physiotherapy and we'll guide you towards that. Keep your brain active, learn new things. Shopping online on Amazon and spending time on social media does not count as stimulating learning things. That is probably a waste of time and money. I'm joking, of course. You must enjoy your lives. But do try to keep your brain active. Learn something new, learn a new language, watch something that's creative, read books. It's important to make sure your vitamin D levels are adequate. Vitamin D has an important function in regulating the immune system. Eat healthy. There is no particular specific diet for MS, but generally speaking, more healthy vegetables, a lot of fish is helpful. Imagine you are on a healthy Greek island, and what would you eat? Think of those things. And the last thing to say is stay positive. It is well known that staying positive and a positive approach to life and illnesses certainly helps improve your brain function. None of us can prevent the illnesses that will come our way. As we say, life is a terminal illness. All of us will have some illness or the other. But how we approach life and its problems will play a big role in how our brains and our lives pan out in the future. That is all from me now. And this is our wonderful Cleveland Clinic MS team, which you have all met and you will meet in the course of the next hour. Thank you very much.
Thanks a lot, Dr. Anu, for your presentation. And now we will move for our second presentation with Dr. Beatrice Benedetti. You may meet with Dr. Beatrice before. So Dr. Beatrice is one of the staff physicians at Cleveland, and she had her medical degree from Italy, and she did her residency in neurology at the same university, and she was focused on the multiple sclerosis and the demyelination disorder. So we'll leave you now with Dr. Beatrice's presentation.
Hello, good morning, everyone. Let me just take a few seconds to share my screen. Okay, share screen. Right. So you can see my screen now, right?
Yes.
You can also see my screen. All right. Okay. Okay, wonderful. Let me just magnify it. All right. Okay, that should be perfect. All right. So again, good morning, everyone. Thank you so much for being here this Saturday morning with us to spend part of your weekend with us. We really appreciate that. So today, in the next about 15 to 20 minutes, we are gonna talk about drugs that can potentially delay secondary progressive MS, and maybe drugs that we can use to treat SPMS. So in particular, we are going to start reviewing what is SPMS, although Dr. Anu already gave us an extensive and wonderful review about that, but we're just going to review it very quickly. So then we're going to move into our topic, which is whether MS drugs can prevent MS. And then we are going to move into a little bit more details about which drugs can prevent or delay secondary progressive MS. And finally, we are going to discuss about which drug we can use if you already have secondary progressive MS to try to treat it. So just to clarify, we are going to use the term MS drugs and DMTs the same way. So DMT stays for disease-modifying treatments, which basically means MS drug. So we're gonna talk about either MS drugs or DMTs during this presentation. All right, so let's start. So first of all, what is secondary progressive MS? So as I said, Dr. Anu already discussed that. So as you know, you should be all familiar with SPMS, which is basically a stage of your MS in which patients develop a progressive worsening of their neurological function. So after having an initial relapsing remitting phase, which is also called RRMS, some patients might eventually transition into a secondary progressive course in which the people will notice a progressive accumulation of disability over the time rather than having relapses. Patients with SPMS, however, as Dr. Anu said, can still have relapses, and in this case, they are called active, or they can have no relapses at all, and in this case, they are called non-active. So those non-active SPMS patients will feel that their disease is continuing to progress, even in the absence of relapses. So, or MRI activity. So as you all know, in people with patients with MS, they have to do MRIs regularly. So the MRI can actually see active lesions, but cannot see everything. So can see active lesions, can see new lesions, but there is something beyond that. So there is something that still happens in the brain of people, even though there are no new lesions or no active lesions. And this can actually, over the time, provoke secondary progressive MS. So symptoms that get worse over the time. All right, so let's move to the second question. So can DMTs prevent secondary progressive MS? Well, you know, this is a million-dollar question because we don't really have an answer to that. But we can try to discuss this today. We have a partial answer to that, actually. I first would like to show you a slide that I always like to show in my presentation. So this picture shows how many drugs, MS drugs, over the time have been introduced in the market. So from 1993, in which we had our first MS drug, which was interferons, up to now, after this picture is not really updated, but anyway, over the years, you can see how many MS drugs have been invented and used. So there are more, we have more than 15 MS drugs now. So it's really, really impressive, and we should be very happy and very proud about that. So coming back to our question, can DMTs prevent secondary progressive MS? Well, you know, as Dr. Anu said, before DMTs were available, so when we didn't have any drugs, or even when we had the very first MS drugs, such as Copaxone or interferons, approximately 50% of people with relapsing remitting MS would transition to a secondary progressive course within 10 years. And approximately 90% of them would transition into SPMS within 25 years. So this is the past, or this is still valid for people with MS who are not taking drugs. But thanks to the drugs that we have available now, so the newer drugs, the course of MS is actually changing. So this is a good news, and I always like to give good news to MS patients. Nowadays, it seems that fewer people with MS are likely to go into a secondary progressive phase. And for people who do go into a secondary progressive phase, this could actually take longer to happen. So we are not able to give you numbers at this point because it's definitely too early, right? Because we've been using new MS drugs only for a few years, but in the future we will know. But we are pretty confident that new drugs can delay SPMS. And there are some preliminary studies that also show that. So when should you, if you have MS, when should you start a DMT? When should you start taking an MS drug? So there are people who are kind of hesitant in starting MS drugs, But the answer to that, according to all MS physicians, is that DMTs should be started as soon as possible in the course of MS. So why is that? First of all, to prevent relapses, because MS drugs are very good nowadays to prevent relapses. And second, because as we just said, DMTs could potentially avoid or delay secondary progressive MS. So if you are not on any drug, don't lose time. Just discuss with your physician which is the best drug for you. So which drug can potentially prevent secondary progressive MS? So I want to show you this study. This has been published recently, I think last April, on one of the medical journals. In this study, they compared a population in Denmark with a population of people with MS in Sweden. So people and then they were treated in a different way, because for some reason, Swedish patients were treated with more effective drugs, while patients in Denmark were still treated with interferons and the old drugs. So they went and they looked into these two populations, and over a time of 7 years, they basically noticed that Swedish patients had significantly lower rate of disability progression compared to people in Denmark during this time of observation, which was up to 7 years, which is quite a good time. So why did this happen? As I just said, this happened because Swedish patients were treated with more effective drugs since the onset of the disease. So they basically didn't take the what we call platform therapies, so the very old therapies, and they immediately were started on medications that are newer and work better. So should everyone start on high efficacy drugs since beginning? Well, you know, lots of patients nowadays are started on high efficacy drugs as a first line treatment, which means from beginning, especially if they have high disease activity, or these drugs can also be used as second line treatment if a patient fails a first line drugs. So this is a graph from the study that I just mentioned to you, in which you can see, I'm gonna try to guide you through this graph. It's not, I mean, it's pretty easy to understand. So the orange-yellow line indicates the Sweden population. So the patients who were started on highly effective DMTs since beginning. And the other line, which is, I think, dark green or blue, shows the Denmark population, which, as I just said, was treated with low effective drugs at the beginning. So you can see here on the left side, the proportion of patients who remained progression-free. So the proportion of patients who didn't accumulate disability over the time. And you can see here the time since the DMT was started. So what we can see here in this curve is that people from Sweden with highly effective drugs, they basically progressed less faster. And there is about 30% reduction in disability progression in people who were treated with highly effective drugs since beginning, or people who were switched to highly effective drug earlier compared to the other population. So which basically means that the drugs we are using now actually work. So let's move now to see, so far we have talked about how we can prevent secondary progressive MS. So we have talked about drugs. Dr. Anu explained you about lifestyle and vitamin D and exercise and diet. And this is all super, very, very important. However, if you already have secondary progressive MS, maybe because you started having MS many years ago, so when these wonderful new drugs were not available, or maybe you didn't start drugs since beginning, so maybe you already have secondary progressive MS, and maybe some of you listening now already have secondary progressive MS. So what to do at this point if you already have secondary progressive MS? Unfortunately, I have to be very honest with you. The drugs we have now do not work so well on secondary progressive MS as they do for relapsing remitting MS. So, and we are gonna look into this in the next slide a little bit more in details. So if you already have secondary progressive MS and you have relapses, we can use exactly the same drugs that we use for relapsing remitting MS. Particularly Ocrevus, Kesimpta, Mavenclad, those drugs, and Siponimod, which we're going to discuss later on, they particularly seem to work on secondary progressive MS somehow as well. So if you still have relapses, those drugs are absolutely still fine. If you are already on a medication and you're doing fine on these medications, so if you don't have any relapse on the medication you're using, you will probably be kept on the same medication. As I said, as long as you don't have relapses. So if you're on a medication, you're secondary progressive, and you somehow feel that you're still progressing with your disability, this is part of SPMS. So it doesn't mean that the drug is not working. This is just part of SPMS. But as long as you don't have relapses, you will likely stay on the same medication. So to better understand why MS drugs don't work so well on SPMS, just want to show you this, this picture, in which partially overlaps what Dr. Anu already showed you before. So you can see in red, in the red line, the disease activity. So at the beginning of MS, people usually have relapsing remitting phase in which they have symptoms, and then the symptoms would recover, and then you have a new symptoms, and then the symptom would recover, and so on. Then at some point over the time, if you follow the red line, you will start having less relapses, but also less recover from the relapses, until the point that maybe you might not even have any relapses, but you might still accumulate disability. So inflammation, which is the light green light, turquoise light, at the beginning of the disease is very important, and it's the major part of the disease. But, and as you know, because you just learned that, MS drugs mainly work on inflammation. However, going on with the disease, degeneration, which is the violet purple line, takes over inflammation. So degeneration becomes the main aspect of the disease. And unfortunately, in secondary progressive phase, in the secondary progressive phase, so that's basically why MS drugs don't work so well in the secondary progressive phase, because MS drugs, as we just said, they work mainly on inflammation and less on degeneration. All right, I hope it's everything clear so far, but if not, we have at the end of the session a Q&A session in which you can ask whatever you want. So let's move a little bit more in details to drugs. So ocrelizumab is a drug that we've been using for about 3 years, I would say. So it's a very good drug. We have plenty of patients on it, and you might also be on ocrelizumab, that you're listening right now. So there are very new data, actually from last April, coming from the American Academy of Neurology, that indicate that ocrelizumab also can have some effect in reducing disease progression and improving cognitive outcomes in people with secondary progressive MS. So that's a very good news. What is Ocrevus? If you're not familiar with it, ocrelizumab is a drug that you receive IV every 6 months. Only the first 2 times it's given 2 weeks apart, and then every 6 months. Ocrelizumab targets B cells, which is a part of the immune system, which is super important in MS. It's what we call a recombinant human monoclonal antibody. Also, to say it more in simple words, it's a biological drug. And it's very similar to rituximab or ofatumumab, which are other MS drugs. Siponimod, it's a drug that has been approved over the last 2 or 3 years for secondary progressive MS as well. So it's taken in tablets, so it's a tablet once daily. But in most of the countries, it's approved only for active secondary progressive MS. But it still seems to reduce disability as well. So as I said, it's a tablet once daily. It's very similar to fingolimod, Gilenya. I would say it's the cousin of fingolimod somehow. So it basically traps the lymphocytes, which is a kind of white cell, into the body's lymph nodes. So it puts lymphocytes in jail, let's say. And this basically stops the lymphocytes to getting into the brain and creating inflammation and damage to the myelin. So according to a study, siponimod showed a 21% reduction in disability progression compared to placebo. Placebo means a dummy drug. So it's basically you take a tablet, which is nothing. So in some study, as you might know, some people will take a dummy drug, a placebo, and some other people will take the real drug. So this is the way how we know if the medicine is working or not. So in this study, those are the patients on the left side are the patient with disability progressive in 3 months, and this is the time. And you can see that people on placebo in the dark red line compared to people on siponimod on the blue line developed more disability, about 21% of difference, which is quite significant. So in clinical trials, siponimod, but this is actually valid for all DMTs, seems to be working more in patients who are younger, who have lesions, active lesions, gadolinium enhancing lesions means active lesions on MRI, had a lower disability and had a shorter disease duration. The benefit of siponimod in people without any relapses or without any disease activity is less clear. So far, we don't really know if siponimod, as well as the other drugs, work for those patients. Let's move to a hot topic now, stem cells. So people are talking about stem cells a lot nowadays. And I must say that stem cells in the form of autologous hematopoietic stem cell transplantation, also called HSCT, might actually work on people with secondary progressive phase, as long as, again, they still have active inflammation. But, and I'm sorry to say that because I know that lots of people think the opposite, even stem cell cannot regrow the nerves or repair the myelin. So stem cell transplantation, yes, it can help people with advanced progressive MS, but who still have active disease, but it will not help people in a very advanced stage who don't have any disease activity. What is a stem cell? A stem cell is a cell that can actually turn into multiple different kind of cells in the body. So a muscle cell, a bloody cell, or a nerve cell, or whatever. So how does it work, the transplant? They basically take, extract the stem cells from your bone marrow. They treat in the lab the stem cells, and then they are reintroduced back into your blood. And in the meantime, you receive a strong chemotherapy. So your immune system is made weaker and weaker prior to receive the treated new stem cell. And then with the hope that this treatment could potentially reboot your immune system. So again, first when your immune system is destroyed, then the stem cell should regrow your immune system in a better way. But be careful. I always want to stress this because there are lots of centers around the world, even in the US, that offer stem cell therapies which are not approved. So always talk to your MS physician, to your MS team, if you want to go for a stem cell therapy, because many of the stem cell therapy around the world might be just not real or fake, or even be harmful for you. All right? Okay. So what is the future of SPMS and treatment in DMTs in SPMS? There are lots of drugs in the pipeline to treat secondary progressive MS. I'm not going to talk about this now because this is actually the next topic and Dr. Victoria will discuss this. But please stay here because there are lots of interesting new drugs that hopefully will be used in the future. So we are towards the end of our presentation. I hope you enjoyed it. So what did we discuss today? First of all, we saw that SPMS can eventually follow a secondary progressive MS phase. We just discussed and we went into the details about the fact that the DMTs that we are using now do not work very well on relapsing remitting. I mean, they do work very well on relapsing remitting MS, but they don't work so well on secondary progressive MS. However, we also got a new good news today, which is that the early use of some DMTs, particularly the newer DMTs, the highly effective DMTs, can delay the onset of secondary progressive MS, which is very good. So if you were already diagnosed with secondary progressive MS, or if you think you might have secondary progressive MS because you feel that you're getting a little bit worse and worse over the time, please go ahead and discuss with your MS team, which is the best treatment strategy for you. Because remember, every patient with MS is different from another one. So you cannot compare yourself to your friend or your cousin or whatever. Your MS is unique and you're a unique person, you're a unique MS patient. So the treatment plan might be different. Your treatment plan might be different from the treatment of someone else that you know. That's why the treatment for MS needs to be tailored, needs to be personalized according to every single person. But your MS team at Cleveland Clinic Abu Dhabi is always happy to help. This is our wonderful MS team at Cleveland Clinic Abu Dhabi. And here we go. I hope you enjoyed it. And thank you for staying here.
So thank you, Dr. Beatrice. And now we will move for our last but not least presentation with Dr. Victoria Mifsud. As well, as I said before, I think a lot of you know Dr. Victoria Mifsud. She's one of our staff, one of the staff physicians at Cleveland. She's the stroke program director. She had her medical degree from Malta and had her university as well. She had her residency in neurology at the University of Buffalo at the United States. She completed as well her fellowship in stroke medicine as well in New York. So we'll go now and start our presentation with Dr. Mifsud.
Good afternoon, and thank you so much for joining us for this MS webinar to mark World MS Day. So today I've been asked to speak about symptom management in secondary progressive MS, and then later to say a few words about future directions. So as you well know, people with MS can experience a whole multitude of symptoms, and they really can affect any part of the body. Hopefully not all at once, though that can be as well. And they really can range from some shaking, some tremor, to imbalance, to difficulty walking, to some numbness, to fatigue and tiredness, to not thinking clearly, just a whole range of symptoms anyway. So as well, because there are so many symptoms, of course, I cannot address all of them, and I will only be addressing the ones which have a little red dot by their side. So of course, managing these symptoms is really crucial because basically our whole aim is for people with MS to live as normal a life as possible and as comfortable as possible. So treating the symptoms is essential to improve comfort, to maximize their function in their day-to-day living, and therefore to improve their quality of life. And because the symptoms really spread everywhere, we really need a multidisciplinary team approach because the expertise that a neurologist might have does not cover the expertise that a language pathologist will have or that a dietitian will have. So we really all need to work together to give the patient the best comprehensive care. And in fact, on this point, I'm just going to show you some representatives of our multidisciplinary team at CCAD. You probably know many of us. So let's start with spasticity and spasms. So basically, when we talk about spasticity, we're talking about that abnormal muscle tone with increased resistance to movement. So if you're trying to bend an arm or a leg, which is spastic, the muscles feel stiff and they're heavy and they're difficult to move. And it may actually be quite hard to actually bend that limb. It can even be uncomfortable or even painful. And as you can see over here, as this woman is walking along, she bends the left leg pretty normally, but the right one is very stiff and she just drags it along. So that, of course, is going to worsen her walking, and it may make it uncomfortable. And she also needs to spend so much more energy for every movement. Sometimes, however, the spasticity can be helpful, because if this right leg were weak, then perhaps without the stiffness, it wouldn't be strong enough to keep her weight. But because there's a stiffness on top, she is able to put her weight on it. So it's something we always have to balance. Now, in addition, very often there are spasms which accompany spasticity. And when we talk about spasms, we're talking about these sudden involuntary movements where a muscle suddenly, or a group of muscles suddenly contract and you cannot control them. And common ones are what we call flexor spasms, where like the leg will draw right up into the tummy, bend at the knee, and often also at the ankle. Extensor spasms, where the leg will just kick out and you can't control it. And even there are these adductor spasms, where the legs seem to want to cross each other. So spasticity tends to fluctuate, and there are triggers which tend to make it worsen, at least temporarily. And these triggers are usually related to discomfort. So being too hot or too cold, or being in a very high humid location, wearing tight clothes, tight shoes, or being in pain, being constipated or in urine retention, or even having some mild infections, which may increase your discomfort. Now, to manage spasticity, first and foremost, therefore, it's important to look for these triggers and treat or eliminate them if they're there. But first and foremost, we tend to go with physical activity. So stretching, if possible, and a simple exercise program are the first cornerstones of treatment of spasticity. If these aren't enough, then of course there are medications. Most commonly, we would start with tablets, baclofen or tizanidine. I'm sure you've heard of both, known as Leorsal or Sirdalud. But these may not be effective enough, or they may cause some side effects like sleepiness. So if the stiffness is in a very specific part of a limb, not like a whole limb or a whole side of a body, then it is possible to inject Botox into that particularly stiff muscle to relax it and reduce that stiffening and spasticity. In more severe cases, then it's even possible to put a pump like this under the skin, so that the baclofen is given as a liquid directly into the spinal canal. And in some countries, though I don't think it is here, there is also an oral spray called Sativex, which is actually a cannabinoid derivative, which I don't think is actually licensed here at all. In some studies, it may help. So the next symptom I want to approach is fatigue. So this is one of the most frequently reported symptoms and one of the most troubling, because it is quite difficult to treat, and at the same time it affects, the physical function, cognitive function, and affects a person's whole life, right? The way they interact at work, the way they interact socially, and as well as their family life. And some people describe it as if they feel as if they're dragging a weight behind their leg, and they have to drag it each time they walk, making them so tired. Fatigue is commonly described as a lack of physical energy, mental energy, or both. And usually it's exhaustion out of proportion to your activity. So it's not as if you've had a hard day at work or you went running and now you're tired. No, usually you've actually done very little and you are extremely tired. And it can come on very suddenly. It can come on so suddenly to just can't continue what you're doing. Some people, say that they feel as if they're an electric doll which ran out of battery and is now just floppy. So characteristics of MS fatigue are that very often they happen nearly every day in many people. They are very often present in the morning, even if they've slept well at night. It tends to worsen throughout the day, but it can also come on quite suddenly at different points throughout the day, and it does tend to worsen in the heat or humidity. But of course, not all fatigue is MS fatigue. There are many other causes of fatigue. So when you're thinking of treating, you really need to look for these secondary causes and see if they might be adding to the tiredness. So, of course, many people with MS do have disturbed sleep because they have other problems, like they need to go to the bathroom a lot at night, or they have painful muscle spasms, which wake them up. So if there's disturbed sleep, of course, that is going to worsen fatigue, and it's important to try to treat the causes of the disturbed sleep. As we said earlier, if you have mobility problems like spasticity and weakness, of course, you're using more energy every time you move. So that is going to contribute to the fatigue as well. Many of the medications that we've already mentioned, like baclofen or the Serdalud, or even some other medications that we use for depression, for example, can actually cause some sleepiness, dizziness, drowsiness. So they would add to the fatigue. Depression, anxiety, low mood are not uncommon in MS, and those, even in any person, are going to add to fatigue as well. And of course, you need to look for other medical things, like maybe there are some minor infections, like a bladder infection, or maybe an underactive thyroid, or any other cause which can cause fatigue in anybody. And also then there's the vicious circle that, of course, because the person has MS, they may not be moving around as much. And the less you move, the less fit you become. And that in itself can also lead to low energy. So when managing fatigue, as we said, try and analyze your fatigue and try and see if this is only MS or if there actually are other contributing factors as well. And if you know that recognize that there are some of these other factors, get them treated. But then importantly, of course, lifestyle changes. That is like the first key. So make sure you're eating a healthy diet, drinking a lot of water, do take short naps to improve your tiredness. Try and work on stress management, and you can consider some relaxation exercises, some meditation. And important, as I've already said, try to exercise at least within your limits. Start slow, but try to introduce some exercise. And in the meantime, try and use whatever energy you have efficiently. So plan your day. If you have to go to 4 different places, see what is the most important and start with that. Try and plan your itinerary so that you're going near each other, not crossing back and forth for nothing. Ask for help. So yes, delegate tasks and do ask for help if you feel that you need it. And pace yourself to give yourself adequate time. You don't stress yourself out, which will then make you even more fatigued. And try and save energy as much as possible. If you can do something sitting down instead of standing, then do it sitting down. It's fine. It will probably help you conserve your energy to do more later. Very often, referral to physical therapy and occupational therapy is useful because they can advise you with regards to an appropriate exercise program, and they can also advise you in case you need any equipment to help you move around more easily. Especially this would be in cases where the fatigue is in somebody with more advanced MS, right? Probably in early MS, this may not be necessary as long as you start doing exercises on your own. Then there are some medications which may help. However, like amantadine, which we often use first line, has been demonstrated to give a small benefit in MS fatigue. And although modafinil is used in other sleep disorders, in MS there are actually conflicting results. And sometimes when available, it is possible to use cognitive behavioral therapy, which is a form of psychological treatment, because this can help teach you to change your thinking and behavior patterns, which can actually be very useful in managing fatigue. So I next will address walking difficulty. And this, of course, will also have a profound and pervasive impact on people's life because it really affects not only themselves, but also their families. And walking difficulty very often consists of an interplay of various different factors. I put it now because we've already addressed both fatigue and spasticity. In addition to that, of course, if there's leg weakness, that's going to cause walking difficulty, and so will significant balance problems. So when managing gait disturbance, difficulty walking, we need to optimize gait by treating the underlying issues like the spasticity, the weakness, the fatigue, or anything else which may be contributing. we also need to try and make sure that the person is as safe as possible, and that we need to try to prevent falls. And in fact, to help with both of these, we would normally refer you to physical therapy and occupational therapy, and often also the rehabilitation physicians, because their input is crucial in helping to manage gait disturbance. And again, as we said before, we usually start with stretching and exercise programs. If you need any help with either a foot drop splint or a cane or a walker, the therapist will be able to advise on that. The therapist can also advise with regards to adapting your house for safety. So for example, people might not realize how carpets or rugs, which are not secured, can easily cause falls when a person has difficulty walking. And then, you know, we need additional help. There's a medication called Vampira. This is useful for helping with increasing the speed of walking, but it does not actually help with balance or strength. So its usefulness is somewhat limited. Pain is another very important part of MS. It is common. About 42% of people have headaches, most often migraine, and that should be treated as you would treat migraine in any other person. About 26% of people will have some kind of nerve pain, and also painful spasms, as we mentioned earlier. And back pain is also quite common, often because people have limited mobility, are sitting around a lot more, and end up with more back pain. So again, to manage pain in MS, treat any underlying causes if they are there. And, you know, as we were saying, treat migraine as you would treat anybody else, treat the spasticity, treat the spasm, treat whatever you think is causing pain. And for spasms, don't forget that sometimes carbamazepine may actually be helpful for painful spasms. And when it comes to nerve pain, what we call neuropathic pain, it's usually burning, tingling, stabbing, and electric sensation, something like that. And it commonly gets worse when a person is lying down in bed at night. And it does not respond to ordinary painkillers. So normally we tend to use more medications which are actually made for something else, because they tend to dampen the conduction of electricity in the nerves, to put it that way. So there are some anti-epileptics such as gabapentin, Neurontin, or Lyrica, pregabalin, and some antidepressants such as amitriptyline, tryptozol, or Cymbalta, duloxetine, which are very useful for managing pain. We're not using them for the seizures, we're not using them for the depression, we're using them for their effect on pain, which is very useful. Coming to bladder dysfunction, this is also very common and very distressing, and it has a huge impact on people's life. And very often we find that the severity of the bladder symptoms are very much linked to how much damage there is in the spinal cord, but not necessarily linked to the presence of other symptoms. So common bladder symptoms would be having to go to the bathroom very urgently or very frequently, or even having some incontinence, waking up at night to pass urine, or sometimes the opposite, going into retention and having either difficulty passing or only emptying the bladder incompletely. So when we're addressing bladder issues, we always exclude a urinary tract infection first, right? Because bladder infections are common and you don't always notice them. One can get some help from pelvic floor rehab and pelvic floor exercises, and there are some medications that can help. But very often we do need to involve our colleagues, the urologists, for their expert opinion. And sometimes also in selected cases, they do suggest using Botox in the bladder, either around the bladder neck or in the bladder valve, to put it that way. Sometimes, however, whatever you do, the measures don't actually work, and the person may actually need to use a urinary catheter or sometimes in diapers. So what about the future directions in progressive MS? So as we've probably heard in the earlier talks, right? And as we already know, we have a lot of medications and we know a lot about MS in the relapsing remitting phase, but we have very little that works in the progressive phase. So in fact, a few years ago, multiple researchers from all over the world and multiple MS societies from all over the world came together and formed this Progressive MS Alliance. And the priority and focus of this working group is to improve the understanding of progressive MS and to increase research so as to develop medications which are effective in this type of MS. So in progressive MS, yes, there is still inflammation, but it seems to change a little bit. So you don't get as relapses so much. You may not get any relapses at all, in fact, and there are fewer and sometimes no new lesions forming on the MRI. And in fact, immunosuppressants are not effective or are not as effective. And in fact, in this phase, it's neurodegeneration, wasting away and loss of the nerve cells, which predominates, the nerve cells and loss of myelin. So if this is what a nerve would look like, with like the wire in the middle and covered by the yellow fatty myelin, as it gets damaged, then there's loss of myelin and the nerve itself gets exposed, and then the nerve itself gets damaged. So the aim of treatment for progressive MS is, one, to work on the immune system to try and reduce the attacks, so immune modulation. Two is neuroprotection, to try to prevent tissue damage and to prevent these nerve cells from dying away and degenerating. And three is to try and repair the myelin that was lost to promote recovery and prevent more tissue damage. So if we go for neuromodulation, for immunomodulation, there are two major, these are what's currently being studied, okay? So at present, there are two major groups of drugs being studied. Masitinib is a tyrosine kinase inhibitor, and these are BTK inhibitors. Both families work on proteins in the cell, and effectively, they both work on the immune cells in the brain and spinal cord. So masitinib, it is thought, probably switches the brain environment from being neurotoxic and aggressive in a sense to neuroprotective. And in fact, in a study, it seems to slow worsening of disability by about 37% compared to people who did not get the drug. The others are being trialed in both relapsing MS as well as progressive MS, and we need to wait and look for the results of the trials for all of these, actually. If you look at neuroprotection, there actually are looking at some old molecules used for other things. So you probably
Ritik, is there a problem?
Yeah, also for me, it's all stuck.
Karishma, Ritik? I'm sure attendees, I'm sure this will get sorted out in a minute. Please hold in there. Okay, I think what we can do is, I think Dr. Mifsud was at the very end of our talk. So maybe we can actually move on to the Q&A. Ritik, can you hear me?
treat them to make them more active, and they give them back to you. And then hope that they will improve the neural function. So this is still experimental, and there are multiple ongoing trials even as we speak. They don't seem to help with the active disease, so that they don't reduce new lesions or things like that. But there is an indication that perhaps there may be some improvement in function even in people with progressive MS who receive this mesenchymal stem cell transplantation. But I have to emphasize, this is still very experimental. We need larger, longer, and properly controlled studies, because we still have to determine the safety, which type of cell is best to use, how it's best to give in the blood or in the CSF, what dose, and whether it truly works or not. So this is, at this point, I would say, watch this space. So in conclusion, clearly symptom management in MS is very important to maintain quality of life, and there's so much more than just medication. A multidisciplinary approach is key because we have to address the problem from all angles. And it's really hopeful to see that there is a lot of active research ongoing in progressive MS as well. So we have to hope for a better future. And overall, the aim is we want everybody to live life and not just to live MS. So with that, I will stop here, and thank you so much for listening.
So now we will move to our last part, the question and answer with the doctor. So we have a few questions here for you, doctors. I will read the question and just ask one of you guys to answer. So first question is, my family member got diagnosed with MS recently. How is it possible to give us support and help them? So I think we have Dr. Victoria, yeah?
Vicky is not available, so I will answer the question. So,
sure.
So first of all, I'm sorry that the family member has been diagnosed. This is not at all uncommon in UAE. Every month at Cleveland, we see at least probably 10 to 15 new people with who have been recently diagnosed with MS. But I must say that MS is now a treatable disease. There are lots of neurological conditions where there is no treatment, but MS is now a treatable disease. And I'm very confident that we can keep your family member very well. Now support, yes, certainly. If you come to Cleveland, we have MS nurses. We have an excellent team, including physiotherapists, occupational therapists, psychologists, and the whole team is geared up towards helping you. I'm sure that is the case in various good hospitals in the UAE. So I'm sure your local MS physicians and team will be able to help you. If you have any specific questions, do email us. And there is an email address that Eslam will say at the very end for the Cleveland MS team. And it is actually MS team at clevelandclinicabudabi.ae. So reach out to us.
Thank you, Dr. Ano. So we'll move for the second question. So I was just diagnosed with MS, and my provider say that my course is secondary progressive MS. If I never had a relapsing remitting MS, how could I have secondary progressive MS now? Dr. Beatrice?
Mm-hmm. Yeah, sure. I'm happy to reply to that. So there are two possibilities here. The most common thing that we see that happens quite often is that people had some symptoms in the past, or even in the very past, maybe when they were 20-year-old or 25 or even 16, maybe they had some numbness or a bit of weakness, and they didn't pay much attention to that. Because then it went away, because we know that relapses usually go away, symptoms come and go away by their own. So a lot of people do have neurological symptoms, but maybe they're mild, and then they go away. So they say, okay, nothing, they don't even might go to the doctor for that. And then after some time, they might develop progressive neurological symptoms. So they might be diagnosed with secondary progressive MS, but they maybe had symptoms in the past. They just didn't pay attention. So another possibility is that it is not SPMS, but maybe it's primary progressive MS. So what is primary progressive MS? Primary progressive MS, PPMS, is another form of the disease, is another type of the disease, which we did not discuss today. In primary progressive MS, which represents approximately 10 to 15% of people with MS, symptoms start gradually. So those people, they never have relapses, and they directly start with a gradual accumulation of symptoms. So it is very important to distinguish between secondary progressive MS and primary progressive MS, because the treatment might differ, and the symptoms might be the same, but the treatment might differ. So just discuss again with your physician which form you have and the best treatment option for you.
Thank you, Dr. Beatrice. So we'll move for the next question. So how rare is for a 17 years old to get diagnosed with MS, Dr. Anu?
Can you repeat the question? How rare?
So how rare is it for a 17 years old to be diagnosed with MS?
It is not rare at all. We have many people who are young and have MS. Children even younger can have MS. There's a whole condition called pediatric MS, which is very similar to MS in adults, but the children often manifest symptoms as young as 5 years and 10 years. So 17 years is a relatively normal age for MS to develop. So yes, that is not okay.
Okay.
Sad? Okay.
Thanks, doctor. So the next question, does all MS patient, relapsing MS patient, have to end with secondary progressive MS? And if so, how long it take?
Okay, I can take this. So not all relapsing remitting MS patients will progress into secondary progressive MS. So as I said before, we had drugs available for MS. Approximately 90% of people would progress into secondary progressive MS at some point, after 25 years approximately. This was before we had our very good drugs. Nowadays, so this was how we call the natural course of the disease. So natural course of MS is relapsing remitting, and then after a certain period of time, secondary progressive. So this is without drugs or with the very mild drugs, so with the very old drugs. So nowadays, with all the good drugs that we have now, which we have discussed a little bit today, it seems that the secondary progressive MS can happen later, or maybe, hopefully, inshallah, will not happen. It's too early to know that, but in the next few years, we will have an answer.
Thank you, Dr. Beatrice.
Can I add to that, please, Eslan?
Sure.
And what Dr. Beatrice was saying, that 10% of patients, even at 25 years or 20 years, may not have progression. And there is this category we call as mild or benign MS. It's how your immune system is. If it's a mild, it's only mildly annoyed, or it's not causing big problems, and the ability of your nervous system to repair is very good. It is entirely possible that a small proportion of people will not have any problems even at 20 years. If you have MS, if you're destined to get MS, it is that kind of MS you should get.
So we'll move to the next question. Does having secondary progressive MS mean I will be ending up in a wheelchair? Dr. Anu.
Yes, of course. Yeah. So I showed you the information before that people with relapsing MS who are not treated, who develop gradually progression, will have walking difficulties. Again, as I said, everyone's MS is different. 10% will not have significant walking difficulties. They may not need a wheelchair, but on average, if 20-25 years, people may develop a degree of walking difficulty that may make it easier to use a wheelchair. Wheelchair usage ultimately may be a choice for some people, but some people do end up in. So each person is different. And unless we know your specific situation, it's hard to comment. So when you meet your neurologist next time, ask the question directly and you can have a discussion at that point. But answering your question, no, just because you have relapsing MS doesn't mean you will end up, secondary progressive MS doesn't mean you'll end up in a wheelchair. but we can, the answer has to be tailored for an individual.
Okay, thank you, Dr. Anu. So we have a question here. So it's a general question. Does the temperature or high temperature affect MS patient?
Okay, I can take this. So yes, it does. So there is something which is called Uto phenomenon, which basically means that people with MS, when they are exposed to the heat, which can be having a hot bath or a hot shower, or maybe the sauna, jacuzzi, Turkish bath, or even if the weather outside is hot, like in summer in the UAE, or if they have fever, they might experience a temporarily worsening of their symptoms. So for example, if they have a little bit of numbness in the leg, when their body becomes hot, they will have lots of numbness in the leg. Or if they in the past experience some blurry vision in one eye, which maybe even recover, if their body becomes hot, the blurry vision can come back. This does not mean that it's a relapse. It's a temporary phenomenon, as I said. So once the body temperature will come back as normal and cold, the symptom will go away. So the symptom might last only 1 or 2 hours, depending on how long the body stays hot. So this is not a relapse. It's a normal phenomenon because the nerve conduction over the neurons, when the neurons are warm, it becomes slower. So MS is a matter of velocity of the conduction across the neurons, right? So with the hot becomes lower. So that's why people with MS cannot be comfortable with the hot weather. And we always recommend to them, for example, if you are in the beach, you can take a bath in the swimming pool or in the sea to cool down your body temperature.
Thank you, Dr. Beatrice. So Dr. Anu, next question is, if our brain is the biggest in size when we are in our early 20s, and we could diagnose with MS before that, how does it affect our brain size?
Okay, so I suppose the question is, if you get MS before our brain becomes full, then how is it going to affect the brain size? So you're right. So if MS begins very early, let's say a child before less than 10 years old, they develop MS. Will it affect the growth of the brain? To some degree, yes. The damage is happening early, so there is a risk that the brain growth or the damage from the MS will cause, on one side, the brain becoming smaller quicker than expected, and on the other side, the brain is trying to grow as is expected. So there's a mismatch there. So yes, it is not good to develop MS early in life. Yes, that is the answer to that question, I guess.
So the next question, actually, there are 2 questions, looks like too close to each other. So I'm gonna say both and we'll get the answer from Dr. Beatrice. So most MS medication works with relapsing remitting. So we know that with secondary progressive, it's like not really that much helpful. So is it possible to stop DMT? The other question is, I have been told that after 40 years old, I can't stop medication. Is that true?
All right, so I will start from this last question. 40-year-old is really too early. So at the age of 40, nowadays, people are still considered very young. So usually what it happens, so the immune system gets older with you. So there is something called immunosenescence, which is a little bit a tricky word to say, but it basically means that your immune system gets older as you get older, and by becoming older, it becomes less active. So that's why most of the people, by becoming older, they might have less disease activity, less relapses, and less MRI activity as well. So 40, however, it's usually very early to say that you might stop your MS drugs. So we're talking about stopping MS drugs later on in the years. And we don't know exactly when is the exact time to stop MS drugs. So what I always say to my patients, we start MS drugs, we start for sure, as soon as possible, as I said, once the diagnosis of MS is done. But we are not making a plan for the future. We are not making a long-term plan. So over the years, year by year, step by step, we will see if MS drugs will be continued or changed or continue the same or stop or whatever. So usually if the person becomes very disabled, which means, cannot walk, cannot use the arms, etc., maybe it's time to stop, but this might be decided for every single patient. For example, even if you cannot walk because you're in a wheelchair, maybe you can still use your arms, and arms are super important for you. You can do a lot of things with your arms. So it might be still worth it to continue with your drug, because maybe it will help preserving your arms, and your arms are what you use to do everything once your legs are paralyzed. So again, there is no exact time. We cannot say age of 40 or 50 or 60. It really depends upon every single patient. And this is a discussion that, again, needs to happen in a personalized way with your physician.
Okay, thank you, Dr. Mifsud. Dr. Anu, do you want to add something?
Yes. So, I mean, we know all this information, what Dr. Beatrice was saying, from people who did not really take treatments in the past. We have very effective drugs at present, and we do hope that the vast majority of people with MS, who've been diagnosed with MS, will not be in a situation where they will need wheelchairs and so on. So we hope that SPMS would be a very rare thing in the future. When I began seeing MS nearly 25 years ago, the clinics were full of people who had SPMS. But nowadays, most people come to our clinics who are able to walk, and they're doing life as normal. So that is what we expect for, and that's mainly because we have very effective new drugs, and diagnosis is being made early. And I'm sure that will be the case for many of you.
So we'll go for the next question we have here. So I think this is, let's go for this one person. Is Kesimpta an effective medication?
Is Kesimpta an effective medication? Yes, it's an effective medication. Yes, it is one of the drugs that kills the B cells, which as we said earlier, it causes a lot of inflammation. And we know that Kesimpta is an excellent medication for MS, yes. There are other medications in the category, including ocrelizumab, rituximab. They all work quite similarly.
Okay, thank you, Dr. Anu. Dr. Beatrice, just another question. It's just more connected to your one when we said about the temperature. So they are saying, so is it better to prevent than going to water park or any exposed to water sports, since usually sun hit the body there?
No, not really. I mean, water parks are really fun. So we want people with MS to live as much as possible a normal life. So if you like water park, or maybe your kids, they like water park, and you're enjoying water park, just go to the water park. It's absolutely fine. So the sun itself does not harm. Actually, the sun is a source of vitamin D, which, as Dr. Anu said before, it's super important for MS. So the sun itself is good. You just have to avoid overeating. So again, if you go to water park, just make sure that you take plenty of showers, that your body temperature stays, cold and not too hot. So if you're going to water park and you like it and you feel good, absolutely, go to water park.
Sure. Thank you.
Yeah. So as Dr. Beatrice was saying, in case it's just not clear, so the damage from increased heat, it just makes the signal in the nerves travel a bit slower. And once you cool down, it becomes okay again. No permanent damage is happening. So to avoid fatigue, getting fatigued too quickly, you should avoid getting overheated. That is the message.
Okay. Thank you, Doctor. So the last question as well goes for you, Dr. Anu. Are there a different type of secondary progressive MS?
I will answer that in just a minute, because there's a question I accidentally answered early on. It is about diet in MS. And the question was about Terry Wall's diet. So for those who don't know, there are two kinds of diets that are proposed in MS. One is called Terry Wall's diet, another one is called Swank diet. They kind of say the opposite things. The Wall's diet says that we should be eating, MS is a new disease, so we should be eating really things that our ancestors used to eat, more of meat, more of dairy, and so on. While the Swank diet, these are both people, okay, Terry Walls and Roy Swank. Swank diet says that no, you should be eating more of fatty substances, etc. So they're kind of opposite, but and there is no conclusive study that tells that either of them is better than the other, or if they're really beneficial in the long run. When we talk about MS drugs, we're talking about their benefit in 20 years time, 25 years time. But for these diets, we really do not know any effect on the long term. In the short term, some people find that it reduces fatigue. The patients lose weight. Maybe that's the reason why people are feeling better. So we have no particular recommendation, But in general, as I said, think of if you're living on in a Greek island, like a Greek, a healthy Greek, eating lots of vegetables, fish, getting exposed to good sunlight. Think of it in that way. We cannot say a specific recommendation regards a diet. Aslam, going to your question, are there different kinds of secondary progressive MS? I think we've discussed a little bit. So SPMS is a state after relapsing MS when there is gradual worsening of mobility and relapses may become. And that depends on person to person. Some people may have a gradual progression without any attacks on top of that. Some people may have relapses and then gradual progression. And some people may remain at a baseline for a very, very long time. So these are the kinds of types of secondary progressive MS.
Thank you, Dr. Anu. So I think we had answered all the questions we have. So if you would like to say anything.
Yes. One of the agenda items for today's discussion was about the MS Society. And unfortunately, the MS Society organizers could not make it today, but I can say a few words about it. We all know that it is important for patients to have a voice, a society, a forum to represent them and to give them impartial advice about MS. And we have MS societies across the world, in the US, in the UK, and you must have looked at these websites. In the UAE also, there have been attempts in the past to have an MS society, but we are all busy people and we get caught up in various things, and then the pandemic came. So it really has not really progressed further. But fortunately for us all, the government of UAE, particularly the Crown Prince Court, has decided that it's an important thing to develop, and they have entrusted a certain people to develop it. And we've had several meetings about this to develop a society that is meaningful for all of you. And a lot of work is going on behind the scenes. And hopefully in the next 6 months, there should be an announcement, there will be a website, and they will be reaching out to you with the surveys to ask what you people need to improve the care of people with MS in UAE. So we will inform you when a survey is launched so that you can participate and tell the government what you would like. Back to you, Aslam.
Anu, and thanks for all of you who attend today the presentation. As Dr. Anu mentioned earlier, we have our email where the patient, if they would like really to ask any question or get any more information, we have our email, which is the msteam@clevelandclinic.abu-dhabi.ae. And as well, we have our WhatsApp number. And this WhatsApp number, it's just for any emergent question, that if you have any concern, anything you want to share with us, either me or my colleague Gina, the number will be 052-469750. Please be happy to message us anytime. We answer all the question comes through the WhatsApp usually within the working hour. We do work up from 8 to 4, and we don't do weekend. So please, it's not for any emergency. It's only for any concern. And we are happy really to have you today, all of you. Dr. Anu or Dr. Beatrice, if you want to say anything.
Beatrice?
Yeah, just wanted to thank again all of you for being here this Saturday morning. And I hope that we were able to give you some positive message as well, because I always like to give positive messages to our patients. So as Dr. Anu mentioned before, secondary progressive MS was bad in the past. So I also started treating MS many years ago, almost 20 years ago, and we did have a lot of SPMS patients. But nowadays, if you come to our clinic, most of our patients are doing fine, are walking. So secondary progressive MS is changing, is becoming less an issue compared to before. So it's again, like there is a lot of research going on MS almost every year, new drugs. So please just be positive, because this is so important.
Thank you, Dr. Beatrice.
Thank you everyone for joining us on a Saturday morning. We wish you all well, and do have some local, do not be afraid to tell people about your condition. Everybody will have illnesses, so that is normal. Do share with people. Try to organize some local meetings or in your localities about increasing awareness about MS. And I hope you all have a good weekend ahead.
Thank you, doctors. And as doctor said, hopefully all of you will enjoy the weekend. And we are really thankful for you all to join us in the very early morning on the weekend day. And we'll see you for sure next time.
If Aslam is gone, I see. Okay. Okay. So Beatrice, you still there?
Yeah, I'm
If
still here.
The audience, I think audience is still there. Okay. We'll catch up later.
Sure.